Good afternoon. My name is Deborah Stafford, and I am with Roar Care, a cancer advocacy organization. And I am here today to introduce Julia Levine. Julia is a metastatic lobular breast cancer thriver of 7.5 years. She is founding steering committee member and research advocate with the Lobular Breast Cancer Alliance since 2016. Her roles include metastatic advocate lead, research librarian, and patient and research advocate. She is currently the metastatic liaison between LBCA and the Metastatic Breast Cancer Project, Living Beyond Breast Cancer, and breastcancertrials.org. She is a member of the Cancer Support Community Los Angeles and does peer-to-peer mentoring in the stage 3 and 4 breast cancer support group from 2013 to present. She is also involved as an advocate with MetaViver and GRASS poster talks. She has attended the San Antonio Breast Cancer Conferences, Teresa's Research Foundation, MBC conferences, and Harvard Medical School New Horizons conferences representing LBCA, and she is on the planning committee for the second International Invasive Lobular Carcinoma Conference at the University of Pittsburgh, which is unfortunately on hold due to the COVID pandemic. She is advocate co-author on 2 lobular-related posters, the 2019 San Antonio Breast Cancer Conference poster, Survey of LBCA, sponsored website, Users Confirm Value, Identifies Unmet Information Needs of Patients. And just out from the 2020 European Breast Cancer Conference, Unintended Bias in Clinical Trials, the prevalence of entry criteria that excludes patients with invasive lobular carcinoma from actively recruiting metastatic breast cancer trials. Julia participates in research advocacy to advance her knowledge and provide a patient perspective in the development and implementation of studies in metastatic and lobular breast cancer. Her background as a metastatic patient combined with her advocacy experience gives her a unique perspective with which to try to help facilitate important advances in breast cancer research and specifically lobular research. She has been attending the Komen Metastatic Conferences since 2013 as an attendee and gave her first talk on lobular breast cancer at a breakout session at the 2018 conference. She enjoys using her knowledge to help patients, clinicians, and others in understanding how lobular breast cancer is different from ductal breast cancer and how it can help guide decisions from diagnosis through treatment. Thank you so much for joining us today, Julia, and I look very much forward to your presentation.
Thank you, Deborah. And thank you to the Komen Metastatic Breast Cancer Conference for allowing me to speak on lobular breast cancer. Can you guys hear me okay? Okay, so my name is Julia Levine, and some of you may know me as Julia Catherine on social media. I was diagnosed in 2013 with metastatic de novo lobular breast cancer, meaning right off the bat, in 2013. My tumor was 7 centimeters on imaging, and I had metastasis to the bone. Now, none of my doctors explained to me that ILC may be different than IDC, and what to look for, where else it might spread, and the fact that it might be harder to detect on imaging or that surgery may not clear the margins. I'm a research fanatic, and I researched all I could about ER-positive metastatic breast cancer, my therapy that was recommended, and whether surgery was a good option for me. But I never thought to research what ILC meant on my histology. So in 2016, I saw a post on Facebook about the first international symposium on lobular breast cancer, and that kind of put a light bulb on in my head. And so I decided to go, and there were researchers and clinicians, patients from all over the world talking about lobular breast cancer. And after that conference, Lee Pate and several others of us decided to form the Lobular Breast Cancer Alliance. And our goal is to help educate others and raise awareness about lobular breast cancer. So my disclaimers are that I'm not a scientist or a medical professional in any way. As a matter of fact, my high school biology was my last science class. But everything I say here is backed up by research and vetted by Lobular Breast Cancer Alliance's Scientific Advisory Board. So I'm a patient that has been through most of what I talk about, and I've let research guide me every step of the way. I'm also an advocate that is passionate about research, and I like to help and educate others about the differences between ILC and IDC and how it might affect diagnosis, imaging, and treatment. I've tried to make this patient-oriented a basic overview. I don't know about you, but when I see doctors, often slideshows are just so much math and graphs, and a lot of it just goes right over my head. And also updating you on the current research. So I'm also excited to have the fabulous Dr. Weissman for Q&A, who will answer questions after my talk. Okay, so next slide, please, Darren. So lobular breast cancer is the distinct subtype of breast cancer with unique cellular structures, biology, and behaviors. And it's the sixth most frequently diagnosed cancer of women in the United States. But only 10 to 15% of all breast cancers are of lobular histology. So it's not a rare cancer. There's about 40,000 new cases a year. And lobular breast cancer can recur or metastasize many years after initial diagnosis and is generally slow growing. So they also call that late recurrences. Next slide, please. So here's some pretty pictures of what lobular breast cancer looks like under the microscope compared to ductal cancer. So the first slide on the top left is a ductal carcinoma or cancer, and that you can see it looks very even and cohesive. And right under it is a lobular cell, and that is much more linear, and that's basically mostly what it looks like often under a microscope. And then the middle slide on the top is more of a close-up view. The red areas is the cancer, and as you can see, it kind of has a ribbony feel to it in the close-up. And then the one right under that is just looking at more irregular cells in a different slide. And then there's several different subtypes of lobular cancer. The classic, pleomorphic, which tends to be more aggressive. And then there's also mixed ductal and lobular, so you can have both ductal and lobular breast cancer at the same time, either in the same breast or in opposite breasts. And then there's some more rare subtypes, alveolar, solid, signet ring, and mucinous. And those are less common. Next slide, please. Okay, so when it comes to metastatic lobular breast cancer, it commonly spreads to bones, but it can also spread to unusual sites, such as the GI tract, which includes stomach, intestines, colon, esophagus, the peritoneum, which is the lining of the abdomen, and ovaries, and rarely to the eyes. And there was actually a recent study talking about cancer to the eye or the orbit, and there is a new study out about that. So like ductal cancer, ILC can also spread to the lungs, the liver, and the brain, and that's usually the tissue linings. So symptoms to report might be bone pain, abdominal pain, bloating or distension, pelvic bleeding, shortness of breath, and headaches. If you have any of those, definitely report them to your doctor. So some of the studies have shown that ILC was less likely to affect the lungs and the central nervous system than was ductal. But by contrast, these unusual sites are more common. Next slide, please. So imaging is challenging in lobular breast cancer. Like you can see in the slides, they grow in a single file. The cells grow in a single file, like branches on a tree. Or I've also heard them described as fingers or lacy pattern. And they can be difficult to see in imaging. So when it comes to finding it in the breast, ultrasound is a good adjunct to mammograms and may see more lobular tumors in the breast. And MRI may be very useful for detection of malignancy in the breast. And there's a new upcoming study looking at contrast mammography, and that's a trial called CMIST. It's not open yet because of COVID, and that's for early stage at this point, but it's looking at detecting tumors in the breast. Might be good for lobular as a cheaper and more inexpensive alternative to MRIs. Next slide. Okay, so imaging for metastatic lobular breast cancer is a little more challenging. So currently, FDG PET and CT, which is the PET that you get that everybody uses, it's a glucose uptake. So often you have to drink a drink. And it's been shown to be more accurate than CT and bone scans for bone metastases. However, ILC on average is less FDG avid than IDC, meaning that ductal tumors are easier to see on those scans than lobular. And mets to the peritoneum and the gastrointestinal tract might be better evaluated by CAT scan or CT. So if gastrointestinal or colon mets are suspected, a colonoscopy or endoscopy may be recommended to better detect caking or thickening of the tissue lining. And then there's a slide here, a picture of a colonoscopy biopsy. So next slide, please. Okay, this is really exciting. And this is newly FDA approved. So there's a new imaging agent. It's called FES, and it picks up estradiol or estrogen. So it's using an estrogen tracer instead of the glucose tracer. And there was a head-to-head comparison recently, and they compared FES PET to FDG PET. And as you can see in the slide on the top, you could see a lot more dark spots than you can with the FDG PET. And this is for lobular breast cancer. So as you can see, it's definitely shows up more. And that's looking at estrogen in the tumor. So it will only work for estrogen positive breast cancer, and they're still studying it. So there's also, it's showing promise in showing efficacy of endocrine therapy. So they can look, there's a trial now, and it's looking at outcomes with ER positive metastatic breast cancer, including those with brain metastasis and lobular histology. So it's hopefully going to be a good therapeutic tool as well, and to see whether your estrogen drug or anti-estrogen drug is working. Next slide, please. So when it comes to surgery, lobular breast tumors are often larger than ductal tumors and more difficult to see on imaging due to their diffuse pattern, leading to less clear margins and more frequent surgeries and more mastectomies. So a retrospective study in 2018 showed that using oncoplastic techniques and shave margins during lumpectomy for lobular tumors can lead to more clear margins and fewer mastectomies. So oncoplasty is a technique for removing extra breast tissue and then rearranging it for a better outcome, and shave margins is a technique for moving the extra tissue around to clear the margins. And this is just a technique that can work well in lobular breast cancer and lumpectomies, and it's a good way to maybe avoid mastectomies. But surgery in metastatic lobular breast cancer, or metastatic breast cancer in general now, is controversial. So 6 to 10% of metastatic breast cancers are diagnosed de novo, like right off the bat. And surgery for removing the primary tumor, like I said, is controversial, and several retrospective studies have shown conflicting information. So recently, next slide, I'm sorry. Next slide, here it is. Okay. So recently, just this year, a randomized study presented at ASCO in 2020 called E2108 determined that there is no survival advantage in mastectomies or lumpectomy with radiation in metastatic disease. However, There may be exceptions for local recurrences, symptomatic tumors, and oligometastatic disease. So oligometastatic means 5 or less tumors in a single organ, and that's being studied. And I just want to say that there's still controversy around this, and there's still researchers that may disagree. So it's really something to discuss on a case-by-case basis with your oncologist and your surgeon and your radiologist. And when it comes to oligometastatic disease, there may be a use for it. And then there's another study that's not out yet looking at this, a large one as well. And there's studies looking at SBRT or stereotactic body radiation therapy in oligometastatic disease. So I would say the jury's still out, in my opinion. When it comes to treatment, next slide, please. Okay, thank you. Lobular breast cancer is 95% ER/PR positive and HER2 negative. But approximately 3 to 5% are HER2 positive, and approximately 1 to 3% are triple negative. So, as I think everybody knows, your treatment is going to be based on your histology, so whether you're estrogen positive, HER2 positive, or triple negative. And currently the standard of care for lobular breast cancer is the same as ductal. But there is some evidence that ILC may respond differently than IDC to standard of care treatments. However, these studies have only been looked at in early stage ILC. So one study showed, okay, next slide, please. So this big 198 was a large study which indicated partial resistance to tamoxifen for patients diagnosed with ILC. And then another study also showed survival advantage of anastrozole compared to tamoxifen for ILC. And several studies have looked at chemotherapy in the adjuvant setting, so before surgery, that shows that ductal cancers derive greater benefit from chemotherapy than those with ILC. And that doesn't mean that it won't work or it doesn't work. It just means that ductal cancers did better. And they're still studying this. And then recently also an analysis came out, FDA analysis, looking at CDK4/6 inhibitors. And they found that they work just as well in lobular cancers versus ductal. And I'd like to see this in looking at other drugs because I think it's important to know. Next slide, please. Okay, so 35 to 50% of lobular tumors harbor PI3 kinase mutations, and 5 to 15% harbor ERBB2 mutations, which is part of the HER2 pathway. And the reason I talk about these two, besides being more common, is there's actually treatments now for these two mutations. So genomic testing, either by tissue biopsy or liquid biopsy, should be requested in the metastatic setting in order to target specific mutations. And sometimes it's difficult to get insurance to cover. I know that Medicare covers these, but Blue Cross doesn't. And it's sometimes, I think, a challenge to get it, but it seems like it's important right now. I think that now, if you get the PI3 kinase liquid biopsy, it's covered by most insurances. And then rebiopsy of metastatic sites is also recommended if possible upon progression. But this can present challenges in ILC. If you can't see it, you can't biopsy it. And sometimes I think there's areas that you just can't biopsy. So lobular breast cancer deserves to be investigated separately in prospective clinical trials to define the best treatment and prevention strategies. Next slide, please. Thank you. And this is a slide just showing a graph. So the main hallmark of lobular breast cancer is a mutation in the CDH1 gene, and you'll see that reflected there on the top. And the second most common is the PI3 kinase. And then you can see all kinds of other mutations. And the only ones that, well, I know that of course, there's therapeutics for BRCA, which is down at the bottom. And then the ERBB2 and ERBB3 are down there as well. Next slide. Okay, so in terms of clinical trials, there's two major early stage ILC trials looking at, the first one is called PLOPS, and it's looking at palbociclib or Ibrance and endocrine therapy in pre-surgical ILC patients. And the reason this is important for metastatic patients is, and this is exciting, I just found out about this, researchers at Dana-Farber are designing a study for advanced breast cancer using the information they've gotten from PLOPS. And they're finding that the pattern of estrogen receptor signaling in ILC is different than ADC. So I'm looking forward to hopefully telling you more about that study later. And then there's another one, doesn't have a name, but it's studying endocrine response in postmenopausal pre-surgical ILC patients. And that one is looking at all the different anti-estrogen drugs. So it's looking at estrogen, tamoxifen, Arimidex, tamoxifen, letrozole, etc., to see if any of them work better than others in ILC. So that could extrapolate later as well to metastatic patients. And then there's a small study, I just want to mention it because it's looking at intraoperative radiotherapy boost. And it's looking now at lobular breast cancer patients and other high-risk patients to see if you can have less radiation and have if it'll work if you have the intraoperative, which means they do it at the same time as surgery. So one and done. But it's just the boost part. Okay, so there's two metastatic ILC trials, and unfortunately they're both in Europe. One is called ROLO, and it's in the UK, and it's looking at targeted therapy for E-cadherin loss, so lobular cancers, and I believe gastric cancers as well, using fulvestrant, which is the same as Faslodex, and crizotinib, which is a drug that's already approved for lung cancer. And that one is, I think, finished with phase 1, and I believe they're in the process of opening it up larger. I think still in the UK, though. And then there's another study in the Netherlands called Gelato, which is an immunotherapy trial, lobular-specific immunotherapy trial. So it's a combo chemo and immunotherapy. So we definitely need more metastatic-specific ILC trials in the US and everywhere. Next slide, please. Okay, so here's some trials that are not lobular specific, but they may have relevance to lobular patients. And these are just a few. Of course, there's many more trials, and you can find them on Metastatic Trial Search or clinicaltrials.gov. But I mentioned this earlier, the FES PET is looking at response with the FES tracer. And it's predicting response, so that one is open, I believe. And then the SUMMIT trial is important because if you do have the ERBB2 mutation, you might qualify for the trial, and that's using neratinib, which is a HER2 positive drug. And then I listed an oral SERD trial. This is called SERENA-2, but there's many other ones going on, and that is, of course, looking at an oral way to take fulvestrant or Faslodex instead of the giant shots. And that will be great if those are approved. And then there is a trial that I wanted to mention. It's in the UK. It's not ER positive specific or lobular specific, but they were looking at liquid biopsies and then matching women with breast cancer to a range of different treatments. There's one more I want to mention, and I just found out about it. I don't know that much about it, but it's called TAPER, and it just opened an arm. It's a basket trial, so it's looking at all different types of cancers, but it just opened an arm that looks at rare mutations like ALK, MEK, and ROS1, and it's using crizotinib, which is the same drug as the ROLO study. So I have a friend that's enrolled in that now, and hopefully, more breast cancer patients and more lobular breast cancer patients can qualify. Okay, next slide, please. So in addition to the clinical trials, there are a lot of labs around the country that are studying lobular breast cancer, and you may not hear about them as much, but they're studying things like estrogen resistance, metabolism, immunotherapy, oral SERDs, like I mentioned, and many more things. Most of those studies are up on our publication library. And we're partnered with the Metastatic Breast Cancer Project, and this is really important. It's, the Metastatic Breast Cancer Project is collecting tissue samples from metastatic breast cancer patients. They collect blood and tissue samples and medical information that's used for transformative genomic studies that will ultimately lead to a better understanding and faster advances in the treatment of metastatic breast cancer. And they are collecting lobular samples. And as of now, there are 394 registered lobular patients. And if you haven't signed up, I really encourage you to do so, because our goal is to get as many lobular samples as possible, because researchers can go onto their portal and use these samples, in their studies. And there's other organizations that we partner with. One is breastcancertrials.org, which has a metastatic trial talk and a metastatic trial search. And they are also including lobular now in their search, so that we're grateful for that. And then there's Share Cancer Support for support. People can go online or call and speak to somebody else who might be in their situation, and they have a page on metastatic breast cancer, as well as Living Beyond Breast Cancer, who did a webinar with one of our scientific advisors this past year, virtual, which is on our website. And they also have a metastatic page, and breastcancer.org has a great description of the different types of lobular breast cancer, as well as symptoms. And they also have a page where you can talk to other people, if you're not on Facebook and you prefer to use email or web. And then, of course, there's several ILC patient-focused Facebook groups, and those are listed also on our website. So you can go to lobularbreastcancer.org to check those out. Next slide, please. So what you can do is communicate with your medical team about your ILC diagnosis and how it may differ from IDC, and educate yourself and others about ILC. Participate in research and clinical trials, or become an advocate. We have volunteer sign up on our website. We have a lobular advocacy toolkit you can download. And one thing I'd also recommend is, if possible, to meet your radiologist, talk to your radiologist, try to see your scans, tell them about your lobular breast cancer and what they need to look for, because they may not always know. And unfortunately, sometimes the same is true with clinicians and others. So we need to be our own advocates, whether or not you become a patient advocate or a research advocate. Definitely important to just be your own advocate. Next slide, please. So about Lobular Breast Cancer Alliance, our mission statement is to make all who are touched by ILC aware of its unique characteristics and the critical need for more ILC research, to be the go-to source for information on ILC studies, clinical trials, and educational tools, to foster relationships among patients, scientists, and clinicians, to increase dialogue about ILC and patient advocacy, and to fund vital ILC research. And the picture below is the bottom left is Lee Pate, our founder, then me, then Lori Hutchinson, who is our new executive director, Lori Petiti, who was one of our co-founders, and behind is some of our scientific advisory board members, Steffi Osterreich, Rachel Jankowitz, Otto Metzger, who looks about 2 feet taller than me. It's pretty funny when we're together. I hear an echo all of a sudden. and Patrick Dirksen. Darren, can you see why there would be an echo? Okay, well, this is my last slide. So, do you guys hear an echo?
Yes.
I'm going to finish this last slide and then see if... Okay. Darren, do you know why there might be an echo? Okay, it seems to be gone. Okay, thank you. So, since 2017, when Lobular Breast Cancer Alliance was actually formed, we have an accomplished scientific advisory board, a website, which I mentioned, which is go-to information on lobular breast cancer. There's webinars, interviews with researchers, publication lists, and trial and research opportunities, and we're working on all kinds of new things for the website. We have a newsletter with over 3,100 subscribers, and we have a Facebook page, Twitter page, and we're on LinkedIn now. We had 2 posters that were mentioned at San Antonio Breast Cancer Conference, and we're building partnerships with national and international organizations. And our future goals are to become an independent nonprofit and fund ILC research. Next slide, please. And I just want to thank the LBCA Scientific Advisory Board, Dr. Weissman from City of Hope, Deborah Stafford, thank you for moderating, who's a patient advocate from Roar Care, and Sharon Schlesinger, who's the founder and chair of the Metastatic Breast Cancer Committee, Susan G. Komen Los Angeles chapter, for putting together this amazing conference, and lobular patients and researchers worldwide. And we also have a booth, an exhibit booth, where you can get more information and enter a raffle to receive a mug. And thank you so much. And with that, I'll turn it over to Deborah to introduce Dr. Weissman for a Q&A. Thank you.
Thank you so much, Julia. That was an amazing presentation, and I learned so much from you as always. I am honored to introduce Dr. James Weissman. Dr. Weissman is one of Southern California's best known and most respected experts on breast cancer. He is currently a clinical professor in the Department of Medical Oncology and Therapeutics Research at City of Hope. Before joining City of Hope in 2013, Dr. Weissman was medical director for research at BreastLink Medical Group in Orange County. He was also associate clinical professor of medicine at USC's Keck School of Medicine, vice president of the medical staff at USC Norris, assistant professor of medicine at UCLA, and the medical director of Cedars-Sinai's hospice program. Dr. Weissman began his subspecialty in breast cancer in the mid-'80s. He received his medical degree from the Medical College of Wisconsin and completed his internship, residency, and fellowship at Cedars-Sinai Medical Center. He has authored numerous peer-reviewed articles, abstracts, and book chapters, and regularly lectures to patients, survivors, and advocates in the community. In the mid-'80s, Dr. Weissman and his colleague, Dr. Mel Silverstein, founded the Van Nuys Breast Center and conducted some of the pioneering work on the management of ductal carcinoma in situ, which led to the development of the Van Nuys Breast Prognostic Index. Passionate about every aspect of patient care, Dr. Weissman has always been interested in novel therapies and technologies and has pursued the development of collaborative relationships based on one imperative: potential patient benefit. A bridge builder driven by the very real needs of his patients, Dr. Weissman has created relationships between expert radiology and image-guided tissue acquisition and the identification of molecular profiled tumor targets through collaboration with the tumor molecular profiling experts at Caris Molecular Profiling Institute. As a member of the ASCO Survivorship Care Committee, Dr. Weissman has developed a particular interest in addressing the very special needs of elderly and metastatic breast cancer survivors. Dr. Weissman's philosophy has always been to identify patient need, identify the centers of excellence in that need, and create working relationships to meaningfully respond to that need. It is easy to understand then that his areas of interest are survivorship care, novel metastatic therapies, collaborative models of care, and cutting-edge technologies. Thank you so much for joining us, joining Julia and me today, Dr. Weissman, in our question and answer session.
Deborah, thank you so much for having me. Thank you to the organizers. Julia, that was an amazing presentation. Thank you for that. That was really at the highest level and state of the art in its content. I am here at your pleasure to answer questions. I just would like to say one thing before that. I think Julia really defined the landscape of lobular carcinoma and metastatic disease in particular. What we are seeing more and more, and this really is going to need clinical trial data, is as the therapies get better, as people do better and better for longer periods of time, as lines of therapy get better, meaning first type of treatment for metastatic disease, second type, third type, as the treatment gets better and patients live longer and longer, the tumor is showing that it's going to become increasingly heterogeneous, which means that's increasingly diverse. Tumors that are hormone positive and lobular features are going to turn often into estrogen receptor negative tumors, are going to have these mutations that were mentioned, such as ERB2. And the take-home message for me, for a metastatic population, is be sure your biopsy of tissue is current. It's been a paradigm shift in how frequently now, not only by liquid biopsies, but tissue biopsies, we are needing to find these new changes in the tumor that define its genomic or genetic alterations so that the targeted therapy can be relevant. Otherwise, we're treating anachronistic disease that's not going to be benefited from treatment. So I think the rebiopsy model is just critical, and lobular carcinoma is a prime example of that.
Thank you, Dr. Weissman. Okay, our first question from the audience is, how can we avoid being sitting ducks, just waiting for cancer to munch away at our bodies and our life expectancy? And there's a second part of that question, but I'll let you answer that part first.
Well, I think that, the language is colorful. We would hope that patients don't end up feeling like they are sitting ducks, but we understand what that means when you don't know when the hammer will drop, when you don't know when your PET scans are going to change, when you don't know when your tumor markers are going to be elevated, when you're feeling fine and all of a sudden things are happening. And I think that is a reality. I think that what we are aware of is the data is getting better. The improvement in outcome is overall getting better, particularly in hormone-positive breast cancer. The drugs are getting better, remissions are longer, survival is longer. And I think staying proactive, and I would use the word courageous. Julia mentioned that she has lobular carcinoma, metastatic disease, but she's proactive, she's engaged, she questions, she gets second opinion, she reads the literature. If you aren't interested in the science of breast cancer, and that can be true, then you have a friend or a family member or your doctor who can help guide you so that you become knowledgeable. And I always say it's important to know from the beginning of your breast cancer journey what your histology is, what the tumor is looking like. Is it ductal? Is it lobular? I did a poll once, and this was a few years ago, so I think patients are different. About 75% of patients did not know what their actual histology was, or their pathology, or their estrogen receptor, or their HER2 node. Knowing that is is informing yourself, and you will become not necessarily immune to the progression of the disease, but you will feel engaged in the dynamic. You will be knowledgeable. You can ask questions. Family members can support you. Even in the environment of Zoom, you can be oriented towards knowledge. And I think knowledge is power. So my answer is you don't need to be a passive, vulnerable patient. You have yourself and others who will support you with information and direction.
And maybe just hearing what you've said, Dr. Weissman, and hearing Julia, it seems some of those proactive approaches you can take are to make sure that your radiologist, your medical oncologist, your surgeon, all of the members of your team are familiar with how lobular carcinomas are different, that you find out what would the recommended screening be for, if you have a progression, how often do you need to get the various scans that may show progression, and then get those new biopsies so that you actually know what your current cancer is. And can both of you maybe share a little bit more about maybe some timelines or how to find the right team for you?
Well, the metastatic setting is a bit variable, and I think it's true that that we don't have a single standard of imaging, such as PET scanning routinely. I think it's helpful to do PET scanning, particularly in bony metastatic disease, because healing responses can mimic active metastasis because the bone is healing and looks the same. So standard bone scanning may not be as helpful. Generally, we like to repeat scans a little bit more frequently in the metastatic setting than just at baseline as we do in primary disease or more locally advanced primary disease. So every 3 to 4 months scans should be done. Generally, CT scans of the chest, abdomen, pelvis, and bone scan remain standard. There are insurance issues. FES scanning is really new. It's been in clinical trials for a long time, now more approved. I think that should become increasingly part of the evaluation. Tumor marker monitoring in hormone-positive disease is only positive in about 70% of patients. So you can have progressive disease and have negative tumor markers. But certainly baseline CA15-3 and 2729, which is basically measuring the same protein, can be done. And if elevated, is valuable in monitoring you. So I think also the physical examination is understated. Some patients have occult skin metastasis, lymph node involvement. It's one of the limitations of having telemedicine only, because patients can't be normally examined. The distended abdomen is a silent sign of peritoneal metastasis. So I think, yes, frequent imaging and laboratory monitoring is part of the hallmark of follow-up.
I do want to say that I found we get a lot of questions on Facebook, especially, what scan should I get? Which one's better? And what I've learned from our scientific advisor, Gary Ulaner, who's our radiologist, is that if you find something that works for you once, it's likely it will hopefully will keep working. For instance, in my case, PET and CT will pick up any activity in my bones and in my breast, but it takes a while. So I've found that usually it'll show up in a mammogram before it shows up as on a CT scan or a PET scan in my breast. I've learned that over time because I've had a couple of recurrences in the breast, and then in the bones, the same thing. It takes a while, and then all of a sudden it may pop up as being metabolically active. But for me, I know that the PET CT scans work, and my insurance covers that, so I'm lucky in that respect. So that's what I use. I do know for other people, bone scans have worked for them, and there's some studies out about MRIs, full body MRIs, but that's not routinely used here anyway. So.
Thank you both. And the follow-up question to that is, are there any treatments or clinical trials using alternative therapies like cryotherapy or hyperthermia or anything else that are in the works?
Well, this is a common question, and I think the right answer is that we still base our decisions on scientific methods and research governed by clinical trials. And I think that the problem with alternative therapies, complementary therapies, is much of the evidence is anecdotal, and sometimes if you try to mix them, and by the way, upwards of 30% of patients take herbal medications, alternative supplementary medications. CBD has become extraordinarily popular. And what we don't know is how they impact standard of care, medications. The metabolism is not fully understood. So you can get unusual herbal therapies, and they can impact adversely liver metastasis and so forth. So I do think there are benefits to complementary medicine, certainly supportive therapy, things like yoga, things like standard things like exercise, meditation. So there's benefits, particularly to those kinds of approaches. But the medicinal route, unless it's been clearly shown to be a benefit, and that really takes a clinical trial, we think is potentially problematic.
And Dr. Weissman, can you tell us a little more about how CMIS works?
How what?
CMIS that Julia presented in her talk.
Oh, the CMIS
trial. It's an image.
Right. Do you want me to answer that, or do you want to?
You know the trial probably better than I.
Yeah, so it's an early stage trial, so it's looking at breast tumors, and it's evaluating whether the contrast mammography, so injecting a contrast agent, like when you get in a CT scan, I think into your breast, I would assume. So they're studying that to see if it's actually, if you can see lobular tumors or you can see tumors better than an MRI, or just as good as an MRI, because MRIs are notoriously expensive. Insurances don't often cover them. So it's a trial that's not open yet, but we'll be looking at it when it does. But I think it's only for early stage. But the reason I brought it up is because if it's approved for early stage, then it could be approved for, de novo metastatic patients who, have recurrences in their breast.
And so this might be a trial that patients with lobular carcinomas are early stagers. So if you know anybody in your circle, encourage them to join the study so that we can learn whether it actually visualizes lobular carcinomas better than a standard mammogram. Okay. Okay, we have a couple of questions here. So the understanding of the questioner is that FES PET scans at this time require one to be off of estrogen suppressing drugs or SERM drugs for 2 months before the scan. Will it be helpful in following metastatic progression during treatment without having to stop SERM or other treatments?
Well, currently the research model is to do it at baseline prior to the initiation of endocrine therapy. And then you monitor with the FES scan to demonstrate response. But to start, the clinical trials have not been, as this participant has suggested, done in patients who are already on endocrine therapy. So I think that data is not currently available.
And a second question. Oh, go
I
ahead.
just want to comment on the benefit of the FES scan. As Julia pointed out, it's so clearly more demonstrative of activity in the setting of ER-positive disease. So you want to be sure you biopsy areas that are positive, for example, on FES, because you can get a tumor that is silent and will not be relevant in terms of the endocrine intervention. And that's also important to understand that bone biopsies can be artifactual because of what we call decalcification artifacts. So the estrogen receptor, progesterone receptor, and the HER2/neu may be falsely negative. So it's important to talk to the pathologist because they have ways of dealing with that decalcification, biopsying an area, preferably that is soft tissue, so that the HER2/neu particularly is accurate. But just to recognize that bone-only disease, I saw a question about bone-only disease. As it goes into remission, then identifying areas of activity can be a challenge, and you don't want to biopsy an area that's anachronistic or historical because you might be treating the wrong disease.
Dr. Weissman, what does artifactual mean?
It means that if you get an estrogen receptor negative result, that may be a result of processing the tissue, and you get a false result because you can't measure the true estrogen receptor because of the artifact of the preparation, or the tissue has to be decalcified in order to be cut because it's like stone. So it can't be cut to make a slide. So you have to take the calcification out. By doing that, it makes the estrogen receptor not as reliable.
Thank you.
Thank you. That does seem to propose some challenges. Our next question from the audience is there any hope that CRISPR might lead to positive outcomes in metastatic lobular carcinomas?
I think gene editing is an area of great interest, and I think we talked about the CDH1 gene, and there are tumors that are actually hereditary with lobular carcinoma and metastatic disease, not metastatic, and primary gastric cancers. So I think gene manipulation, with all the potential controversies in that, I think have a potential. It's not been, to my knowledge, used significantly in lobular carcinoma at this time.
One concern which I know the FES PET scans may significantly resolve, but many patients with lobular carcinomas are diagnosed stage 3 when they may actually be stage 4 because it's harder to visualize their metastases. And that means that they don't have the same access to certain clinical trials or disability or get on track for SSDI and Medicare. And what do you think are the most promising technologies that can help make sure you're staged correctly, and what should lobular patients be asking for when they're diagnosed?
Julia, do you want to take that or do you want me to take it?
You take it.
Well, I think standard imaging is still important. You're correct about the size of the tumor being larger in lobular carcinoma. They can be what we call T3, more frequently more than 5 centimeters. The lymph nodes can be difficult to evaluate. Pathologists, sometimes because of these small cells that are streaming, do count on immunohistochemistry in the lymph node, which we don't rely upon as much in ductal cancer, but it can help direct them towards whether or not the patient has a positive nodal metastasis or not. I think PET imaging is still going to be of benefit to find occult disease. And I think the FES has a future for diagnosing metastatic lobular carcinoma earlier, because these patients primarily do have estrogen receptor positive breast cancer, as Julia suggested. Then lastly, I do think increasingly liquid biopsies, and this is being done in clinical trial now, are going to be examined in earlier stage disease. The problem with it, we don't know yet what to make of it. And I discourage patients with early stage breast cancer from having routine liquid cell-free DNA evaluation, because it can be both misleading and confusing. But on clinical trial, I do think there's going to be an increasing place for cell-free DNA or DNA fragments that come from tumor being evaluated for possibly early stage screening eventually, but also for ambiguous patients like lobular carcinoma, where disseminated disease may be found both by circulating tumor cells, stem cell technology, and circulating DNA.
And I know that that lobular carcinomas tend to metastasize to sites that are very uncommon in ductal carcinomas, and some of the specific genetic mutations were addressed. Does lobular breast cancer resemble cancers of other tissue origin that that might help us to better understand how lobular carcinoma is working and how it progresses?
Well, I think that to the extent that it has similarity, and we mentioned the ERBB2 pathway and the ECAD-heron positivity or lack of, positivity, is giving us clues that there are markers, not necessarily specific to lobular carcinoma only, but or to other cancers. I think the ECAD-heron distinction is critical, and you should always ask about that stain being done in questionable cases where you get these mixed pictures of lobular and ductal tumors, and that the ECAD-heron can help separate it out. And that will ultimately, I think, be a target of therapies. The peculiarity of lobular carcinoma is really something that needs to be better understood. Why does it go to the meninges? Why does it go to the peritoneum, much more so than ductal carcinoma? Oh, why is bone-only disease so common in lobular carcinoma? And I think these are ending up being in part of the discussion of metastatic niches, meaning areas where the organ of receptivity of the tumor plays a role, and whether it's the immune system or genomic characteristics of the metastatic site. I think there's going to be understood a interplay between the target organ and the metastatic tissue. And I think you're going to hear more and more about that in the future, probably on an immune basis first, to understand what role the immune system plays in either augmenting or preventing metastasis to certain organs.
Thank you. Thank you so much. It seems like there's been so much progress that I have heard over the past years that I've been hearing Julia speak, and that there is a lot more for us to learn, and hopefully we will get some answers that will lead to better treatments and better quality of life. And I want to thank you both, Dr. Weissman and Julia, for being here today and helping educate us about this important topic.
Thank you so much.
Thank you for having me.
Thank you, Deborah. Thank you, Dr. Weissman. Thank you.
Thank you so much. It was a pleasure.
Thank you. Thank you both.
Have a good afternoon.
Bye.